Welcome, welcome back, clinical problem solvers, for another Friday RLR VMR edition. And we have a very special guest who's presenting today from Dubai with a beautiful accent. Masa, why don't you tell us a little bit about
Hi.
yourself?
Hey everyone, I'm from Dubai. I'm originally Syrian, but I was born and raised in Dubai. And yeah, fun fact about myself is I do theater. And I also am a marathoner. And I'm really excited for the case today. I'm so excited to share this case with everyone and learn from you guys as always.
You know, Masa, it's interesting. There's a good intersection between medicine and theater. In fact, one of my colleagues is studying this space because when we present patients on rounds, or when we're talking to a consultant, or even what I'm doing right now, there's a bit of acting. And especially when Robbie's behind the mic, you would think that he deserves the Academy Award for the way he shares his thinking. But what do you think? Do you have any interest in combining your two passions together, theater and medicine?
Yeah, for sure. I feel like there's a lot of improv in medicine and a lot of confidence that comes from theater is like I use it a lot in medicine. And so yeah, definitely I agree with you.
Well, if you're ever interested, I'll include my email in the chat. Send me an email because I have a he was formerly my mentee, but now he actually performed on Broadway in New York. And one
Amazing.
day while performing in New York, he's like, you know, it's just not for me anymore. I'm not excited. I'm not inspired. And then he pivoted and pursued medicine, but now he's trying to find the landscape between those two areas of expertise. Listen,
Yeah.
Robbie already finished his breakfast. That means I've been talking for too much. So who's scribing and who's teaching today? Maybe you guys can introduce yourselves.
Yeah, hello everyone. My name is Ibrahim, and I'm joining from Jeddah, Saudi Arabia, and I'm doing teaching points today.
Unbelievable. And who is scribing? It's our new AI. I'm sure someone's going to start scribing when we go. But I think it's so cool. We got Masa from Dubai, Ibrahim from Saudi Arabia, Robbie from San Francisco, and me from DC. With that being said, Masa, why don't we kick it off? And Robbie, looking forward to calculating your math.
Okay. Okay, so I'll start. So for the chief complaint, it's a 25-year-old male with decreased level of consciousness and urine incontinence. For the history of presenting illness, a 25-year-old male patient with alcohol use disorder was brought by his friends to the emergency department with decreased level of consciousness and urine incontinence. 7 days prior, he presented with headache and vomiting, for which he was discharged on symptomatic treatment. According to his friends, he has abstained from alcohol for 2 months. His his GCS was 11 out of 15 with right gaze deviation. He was tachycardic and hypothermic. He developed seizures in the emergency department and IV diazepam was administered. He was intubated and admitted to the ICU and started on empirical antibiotics and antiepileptics. For his review of systems, he had altered mental status, no nausea and vomiting, and no shortness of breath. That's all the history we could gather because of his altered mental status. And that's all we got from his friends. So I think I'll stop here.
Oh my gosh, Masa, what an explosive start to this case. Tragic for the patient, but I think really pushes us to be on our toes. And I think if all of you who are yet to see patients, I think we're probably used to VMR having a lot more information that the patient gives to you in the first 5 or 10 minutes. But honestly, this is all probably within the first 20, 30 minutes, given how sick the patient is, and really reflects the reality of what it is to take care of somebody who's very sick. So often you're really left with like, where do I begin to start? And I think the first thing that you'd probably start is to just sit back and ask yourself, do I need to do anything right now to stabilize the patient? And I think that with the patient being intubated and sedated and being given anti-seizure medications, the neurological dimension is as stable as it can be, though there are probably other things that you could do to empirically treat some neurological catastrophes. So things that you might be thinking of in addition to ongoing seizure management is ongoing blood pressure control and seeing if the blood pressure is going to be an issue, and then ongoing consideration for the possibility of cerebral edema and the management needed for that issue. I think this case has such a prominent neurological dimension, which I'll actually leave for Prof. Rez to analyze to see where he's thinking. And if Prof. Rez and I were, if my dream were to come true and Prof. Rez and I were taking care of this patient in real life, I would be glad that he's on neuro and I would stop thinking about it, because I know that these patients are at high risk of ignoring or minimizing any systemic disease that they might have because the neurological dimensions are screaming at us. So I would probably take a little bit more time to make sure he doesn't have a prominent cardiovascular, pulmonary, abdominal fingerprint before indulging in the temptation to call this a isolated neurological catastrophe. But I'll pass the mic to you, Prof. Rez. What are you thinking?
I love the adjective you use to describe this presentation, and you use the word explosive. And it really is that, isn't it? It makes you wonder, you know, he has this past medical history of alcohol use disorder, sober for 2 months per his friends, but we always take that with a grain of salt. And someone who has an alcohol use disorder, if they stop drinking, they are at risk of seizure. So in a patient like this, I would have a very, honestly, I would send the urine tox, I would send a blood alcohol level, in addition to pursuing what I think is the primary problem here. And it's really, Robbie, one specific question I have in my mind from a diagnostic lens. And is there a structural lesion in the brain? Because we got this history of headache and vomiting that preceded his clinical syndrome. And oftentimes, those two symptoms, headache and vomiting, they don't really track together. When they do coexist, it reflexes to make us think, is there something causing an elevation in the intracranial pressure? All that being said, even though these two don't often coexist, and we have to think about that most alarming pathophysiologic state, they can be simultaneously present and unrelated, meaning someone just has migraine headaches and maybe had a bad meal and now is having some vomiting. But it's really hard to even prioritize the common base rate because of what ensues. And what ensues is a couple of focal neurologic findings. The right eyes deviating. That's really like, it's hard for me to think of a metabolic cause that would result in right gaze deviation, assuming it didn't occur during the seizure. And where I would really invest my cognitive energy is I would get a CT scan stat, and I would actually, in my hospital, I would activate the code stroke to expedite everything. But I think step one, is there an intracranial lesion? Something that's obvious. And I'm concerned that that will be the case just based on the presentation that Massa is giving. But if we wanted to just do a quick exercise in like our approach to seizure, whenever you see someone have a seizure, you always want to look at the past medical history. Do they have a seizure history disorder? And this patient doesn't. And then the next question becomes, is it because of a structural lesion or is it because of a metabolic or toxin reason for the seizure? So ultimately, Massa, I think what we would be doing next is quickly getting some form of head imaging and allowing that to sort of guide our next steps, at least from a diagnostic lens.
You guys had a lot of great points. I will get to the imaging later. But for the past medical history, that was insignificant other than the alcohol use disorder. His drug history, he just takes paracetamol as needed. For social history, he's an immigrant from Morocco. He drinks alcohol heavily. According to his friends, he drinks 1 liter of vodka daily, but abstained for the past 2 months. His sexual history and illicit drug history are unknown. His family history is unknown. His allergic history is unknown. On physical examination, his temperature was 34.7 degrees Celsius. His heart rate was 110 beats per minute. His respiratory rate was 18 breaths per minute. His blood pressure was 111/89, and his SpO2 was 96% on room air. On general examination, he had a for cardiovascular exam, he had a normal S1 and S2, regular rhythm, and no lower limb edema. On respiratory exam, he had no added lung sounds. On abdominal exam, no abdominal tenderness and normal bowel sounds. On neuro exam, in the emergency department, he was opening his eyes spontaneously with a right gaze deviation. He was localizing pain and vocalizing. So his GCS was 11/15. His pupils were equal and reactive to light. He had his bilateral Babinski was negative. He had no signs of lateralization, and he was moving all his limbs. He was admitted from the emergency department to the ICU, and in the ICU, he was intubated and on mechanical ventilation. So in the ICU, his pupils were small and bilaterally non-reactive. Shall I give you the labs, or should we stop?
Maybe we can stop here, Masa, if it's okay. And what I can do is I'm going to leave the physical exam for Rabih. I just want to talk a little bit about the social history and the past medical. And this is what I want to say. It's so interesting. When someone stops drinking, we want to celebrate them, and we should. But sometimes it's not intentional. Meaning what? Like, imagine that patient who's been drinking for a long period suddenly stops because they're feeling ill, and that's your first clue that you're dealing with severe alcoholic hepatitis. So sometimes a major red flag is if someone stops, not because that's their desire, but because something feels off about their body, and it's a forewarning to what might follow. So I think it's really important when you guys get into the hospitals, in addition to celebrating sobriety, also asking what prompted the sobriety. For this patient, we can't ask that because he's intubated, mechanically ventilated. But 2 months ago, if I were in clinic seeing the patient, I would want to know more. Is it because that they're tired and how it's affecting their body? Or do they feel like crap and they just don't want to drink? And that's like a red flag that something's about to follow. And then if we just quickly look at the HPI, when you have urinary incontinence and you're concerned for a neurologic problem, you really have to be concerned for the spinal cord. The fact that we have the seizure and the gaze deviation, we know that if there is a lesion, it's going to be above the brainstem where the cranial nerves are, controlling eye movement. Usually if you have fixed gaze deviation, there could be a problem within the brain parenchyma that helps coordinate eye movement, the visual field cortex, or something like that. All that being said, I'm going to pass the mic to Rabih to walk us through the physical exam.
I love that, Prof. Reza. I love the importance of making sure we understand why the patient stopped alcohol use and what implications that has. And I think as we start to understand this picture better, I think understanding the time course of the syndrome is really important. And I think I will update my mental model of this case by adding the word pseudo in front of explosive. And the reason I'm adding the word pseudo under explosive is you don't become explosively hypothermic. And what that tells you is that this has been going on for some time. And what hypothermia is, the very simple mental model of hypothermia is that there is more loss of energy, of heat, than there is production. And in most people, that calculus favors increased loss. And that loss is often due to two things. Either environmental exposures, which are hard to imagine if this case occurred in Dubai, but it's possible, I imagine, or more likely, that the patient is vasodilated. And the most common reason for vasodilation is sepsis and infection, but there are many other things, including the vasodilatory effects of alcohol consumption. And the way you can remember that is the facial rubor that commonly accompanies patients who are drinking frequently. And so the question is there increased loss, and should we think of this hypothermia as a marker of sepsis physiology? But the reduced production arm is really important to think about too. I think the most famous cause is hypothyroidism. We talk about that a lot, and that hypothesis clashes with the heart rate, and where you see usually a low heart rate. But I think it's important to think about heat generation also requiring energy, and patients who are malnourished are higher risk of developing hypothermia. But it also requires the neurological input, specifically from the hypothalamus. And so patients with hypothalamic or even brainstem diseases can often be more prone to hypothermia. There are even really cool disorders of the hypothalamus that are more chronic that cause cyclic hypothermia, and those make it into neurojournals and really cool cases. And so I think the temperature here tells you odds are there's been increased loss, but I think given the devastating neurological catastrophe, we would entertain all those causes, especially sepsis, but move quickly to wonder if there's an endogenous cause in the neuroaxis specifically. And so I think that the question is, the first question we said was going to be really important, that was my job, was to really step back and be like, is there a systemic fingerprint of this disease? And so far there isn't, but that's just so far. The neurological dimensions, I think, Prof. Rez, you hit on, you hit the nail on the head with the gaze deviation. What I'm intrigued by, Prof. Rez, is the fact that he had gaze deviation continuously, seemingly outside of having a seizure, because he was able to communicate and he was localizing pain at the same time that his eyes were gazed to the right. And the ability to communicate and still have deviation, I think, it creates a disconnect between seizure as the sole cause of that gaze deviation. I say that as an amateur. I don't say that with a high degree of confidence because I've never seen gaze deviation without a seizure, ever. But I think if I saw this in real life where somebody's eyes were going one way and they were kind of telling me things like, "Ow, it hurts" or whatnot, I would probably wonder, hey, is this psychogenic non-epileptic seizures? But in this context, that hypothesis is foolish. This person has a very severe sinister syndrome going on. So I'm wondering, is there something continuously doing that to the eyes in the frontal eye fields, or which would be contralateral? Well, depends. If there is a structural lesion, that I'll just step back. The frontal eye fields push the eyes the other way. So this person, if they have right eye deviation, could have hyperactivation of the left frontal region from a seizure. So if you seize from the left frontal region, boom, you push your eyes the other way. What could also be happening, as inferred by the ongoing continuous right gaze deviation, is that the patient has hypoactive right frontal eye field. Okay, and so how can that happen? The patient has a space-occupying lesion there, a stroke there, and that area is deficient. So remember, the frontal eye fields push the eyes the other way. There's another localization for a gaze deviation, and that's in the brainstem. I'm forgetting the specific location in the brainstem. But counter to the frontal eye fields, the brainstem, the eye deviation is ipsilateral to the lesion in the brainstem. Thank you, Mukun. Parapontine something reticular formation. So yeah, so I think the interesting thing that the neuro exam sets us up for is to wonder if there is a structural lesion, because the gaze deviation appears to be outside of a seizure context, and the structural lesion might be in the left frontal region or in the right brainstem. The pupils are often very tricky to analyze in the context of mechanical ventilation, and we see bilateral pinpoint non-reactive pupils. That could be because of the sedating medications this patient got, but let's remember that the sympathetic system also courses through the brainstem, and a bilateral lesion in the brainstem could result in pinpoint pupils, though brainstem lesions to be strategically knocking out the sympathetic nervous system on both sides and causing eye deviation would be probably expected to cause more devastation below the neck in the arms and limbs. So it's a tough localization for me, but I think you really, really need to know exactly what's going on in this patient in terms of their neurostatus. So I know you're keeping the imaging in your back pocket, which I love. It allows us to get a lot more juice out of this case. But honestly, what I would love before we move on is, Prof. Rez, this is beyond, I'm not comfortably analyzing any of this data except the hypothermia. So I'm really curious what other thoughts you have, anything else you want to sprinkle in before we move on?
I had zero thoughts. That was a beautiful analysis.
Yeah, that was amazing. Okay, so should I give you guys the labs now? All right, so for the hemoglobin was 14.2 grams per deciliter. White blood cells were 11,300 per microliter. CRP was 50.2. Sodium was 130. Potassium 4.1. D-dimer 0.7. ALT 16. AST 28. ALK-Phos 116.7. Albumin 28.4 grams per liter, and total bilirubin was 7.9. Should I go for chest x-ray now? These are all the labs I have. I have some chemistry later on, but should I share the chest x-ray and CT brain? Okay, so for chest x-ray, there was multiple scattered small patchy opacities in the left upper lung and congested hilar vascular markings. For CT brain, there were no previous studies available for comparison, but it showed ill-defined hypodensities in the left and right parieto-occipital regions and the right frontotemporal regions. There were no intra or extra-axial bleeding and no acute infarction seen, no mass effect or midline shift, normal ventricular size. There were air fluid levels in the maxillary sinuses and bubbly appearance in all the sinuses. And that's it for now.
Maybe I can analyze the labs and then pass the imaging to you. And I think that caution to make sure that the exam did not hide a systemic fingerprint to the disease in the labs would, and the imaging would, I think has borne fruit. And I think that's a big, big lesson for us all. I shared this from the very beginning, by the way, because of how often I've done it in real life where somebody is seizing in front of you. Who cares about their bilirubin, in that moment? But after the dust settles and after you stabilize the patient, if you're not like focused on that, it's very easy to miss. And so I think here what we have in terms of the labs is now involvement of the bilirubin. And a very simplistic involvement of the bilirubin is to try to figure out if it's hematological or hepatic, with the idea being that if it's indirect, it will be hematological, and if it's direct, it'll be hepatic. Most hematological causes of hyperbilirubinemia, i.e. indirect, will come with an anemia, though not all of them. And so I think it's probably fair to assume that most of this bilirubin, when fractionated, will be direct. And it'll be interesting to try to figure out where in the liver this bilirubin is coming from. Is it coming from the liver parenchyma itself, or is it coming from the drainage system, the biliary tree? And the fact that it is completely isolated, that it is so high by itself with normal AST, normal ALT, and normal ALK-Phos is very intriguing. It's hard to make progress on where it'll ultimately pan out because there's no signal to push it towards the liver parenchyma with the liver enzymes. and there's no signal to push it to the biliary tree with an alk phos elevation. Of course, we have to analyze this bilirubin in the context of the patients having big risk factor for liver disease is alcohol use. The combination of leukocytosis and direct hyperbilirubinemia is evocative of alcoholic hepatitis, which would be an intrahepatic disease process. But I think, we've imaged his brain, we're looking at his chest, and I think to understand the bilirubin, we really need to extend down that imaging to the biliary tree. So unknown, I would say, to summarize, probably liver. I'd say 90% chance liver, and I would say 80% chance intrahepatic for two reasons: alcohol, and most cases of hyperbilirubinemia that feature a systemic disease that is acute is in the liver itself. Extrahepatic biliary tree diseases are often not systemic, think a pancreatic cancer, and when they do become systemic, often do so over a subacute time period. So the fact that this seems to be acute, i.e. not noted on his last visit, and is part of a systemic syndrome, it's much more common for the liver itself to be dancing with the rest of the body than the biliary ducts. But you have to exercise humility here, and these are just pretest probabilities. Thoughts, Parfraz?
Absolutely. I think, Masa, this is such an interesting point in the case because we're now getting data to really help us frame the differential diagnosis. And we're getting clarity on why this patient is ill. And I think what my problem representation would be a young guy with history of alcohol use disorder who's presenting subacutely with SIRS physiology and pathology in the lung and the brain. That would be my simple problem representation, and everything would anchor around the disease that's in the lung and the brain, meaning that the final diagnosis has to be able to explain both. Many times we might scan the lung and see little nodules, and that you can't really make the conclusion that you're dealing with a pulmonary CNS disease because it's just by chance. But in this young individual, and on non-optimal imaging, that's chest x-ray, the fact that they saw patchy opacities in the upper lobe really makes me concerned that we're dealing with a disease that's involving the lung, the brain, and maybe the liver for the reasons that Rabih mentioned. And whenever you're encountering a lung brain disease in the context of SIRS, you have to wonder what is the immune status of the host. And this patient needs an HIV testing because it would help broaden that differential diagnosis from an infectious perspective. But it really makes you wonder, and alcohol itself will compromise the immune system because it's a toxin to the bone marrow, and that's where your immune cells are produced. And then I think at this juncture, you just wonder, are we dealing with an infection, a malignancy, or an autoimmune process? And you would prioritize infection because we have a young individual and the presentation of lung, brain, you just really should prioritize an infectious etiology with SIRS. And for those infections, I'm favoring more of an atypical infection, meaning not your common bacteria like strep or staph, though those are still fair game. So I'm getting a blood culture, I'm getting an HIV test, and I'm broadening beyond the common microbes to include mycobacterial infection, because mycobacterial could be a good fit for lung. You inhale it, it goes towards the upper lobe, it enters the blood, it hits the brain, and then it hits the liver. So you have to worry about tuberculosis. And whenever you say TB, you should automatically consider fungal infections, primarily the dimorphic, and just ask the question, what kind of organisms that are fungal are endemic to that region of the world? Like here where I practice, oftentimes coccidiomycosis comes to play, histoplasmosis, blastomycosis, but you have to be worried about some kind of fungal infection as well. And whenever you say fungal and you're talking about lung and brain, all of a sudden nocardia and actino also become possible organisms. So that's sort of the infectious bucket. And what I would do for that is I would get the blood cultures, I would get the HIV testing. I would start broad spectrum antibiotics covering, gram-negative organisms, gram-positive organisms, but I would also pursue that workup for more unusual organisms. And then the question becomes, where's the easiest site to get bang for your buck? And in this case, it would be the lungs. So I'm sending the sputa for various organisms, and the patient may not even, the patient's intubated. So you might be able to get a good sample, and they're 96%. I don't know what their ventilation settings are, but you might actually be able to get a good sample from the lungs. And that might be the most benign way to actually sample and get an answer. But I'm also thinking we have the brain lesions. An MRI would give us much better characteristics and give us a better radiographic differential diagnosis. But I'm also on alert that I might need to get an LP to see if an organism gets isolated there. For the autoimmune category, whenever you have lung and brain, it becomes more difficult to explain. But the autoimmune stuff that can cause lung pathology includes things like GPA, rheumatoid arthritis can do it. Sarcoid can have a lung and CNS, but usually doesn't leave parenchymal lesions in the brain. And then malignancy, he's quite young, but liquid cancers can mimic, infectious etiologies to the T, stuff like lymphoma. So you might even consider sending an LDH. Bottom line is, we have to explain the pathology in the brain, we have to explain the pathology in the lungs, and we want to explain it through the least invasive form. But most likely you're going to be pursuing stuff in parallel, meaning you're going to go after what's in the alveoli, but you're also going to probably go after what's in the CSF. And just answering the question, what is the immune status of the host?
Reza, that was pearl galore. I think Ibrahim is struggling to decide which font size to use because there's so many pearls you're sharing.
Yeah,
Awesome.
those
Hear more.
amazing. I'm learning so much, honestly. Okay, so I'm gonna move on. I have some expanded chemistry that I want to share. So his HIV was negative, influenza A and B were negative, toxicology, including ethanol, was negative, and toxoplasma IgG was negative. On high-resolution CT chest, there were branching linear and nodular opacities showing tree and bud sign, patchy areas of consolidation. And for brain MRI with contrast, there were multiple ring enhancing lesions with perifocal edema in the right frontal and precentral regions, and in the right and left posterior parietal regions. I'm gonna stop here because the next thing I'll give you will kind of reveal the diagnosis.
Wow, okay, very cool. I'll tackle the CT scan and then leave the brain MRI for Rabih to dissect. And I think it just is a reminder to us that cross-sectional imaging is much better at gaining clarity of the pathology that you're analyzing. And in this patient, there's a few things that Massa shared with us. And one was the tree and bud appearance of the cross-sectional imaging. And actually the first time tree and bud was ever identified was in a patient with tuberculosis. Later, they learned that many infections can cause a tree and bud appearance. And really what it is if you imagine the airways starting with the trachea, then you get the main stem bronchus, and then you go down into your bronchioles, and then finally into the alveoli, which are little graves. Tree and bud literally means that debris is filling up those little bronchioles and alveoli. So you look like a tree with little buds around it. That's all it means. And whenever you have like this sort of scattered nodularity towards the apex of the lung, it really makes you wonder, are you dealing with an oxygen avid atypical bacteria that was inhaled and then has spread to the liver and the brain hematogenously? And so in this context, yes, I would treat with the typical broad spectrum antibiotics that we would do for someone with a severe pneumonia, but I would really be wondering, am I going to find an unusual organism? And those organisms that I'm most concerned for is tuberculosis. And so I am going to see if I can actually sample some fluid from that lung, where I would screen it, for AFB smear. I would do the AFB PCR, and I would send the culture. And if the AFB is partially positive, that might be a reason you start thinking about nocardia and you go beyond, TB. But a fungal infection can do it, and even a typical bacteria can do that as well with the tree and bud opacity. So I'm most worried for an atypical infection or a fungus, less worried for an autoimmune etiology or a malignancy with disappearance of the CAT scan and the sepsis physiology of the patient. But would love to pass it to Rabih to incorporate the brain lesions to see if that allows us to prioritize what's happening in the lungs.
Well, Prof. Rez, I completely agree with you. By the way, I love the idea of the oxygen of avid organisms. That really helps make it stick. That was really cool, Pearl.
I wanted to use the word aerophilic, but I wasn't confident enough. But I think that is a word, isn't it?
I think it is the word, yeah. Heck yeah.
AERO. I don't know. I think that's what it is.
Always
but I wasn't confident, It's like when you do the golf swing, you want to be confident and go through all the way. I usually stop at impact, but I'm just not a confident golfer.
I fully understand this analogy without any hesitation. I feel like Prof. Rez, you just like all the world, you see the world through golf now, huh? Is that your prism? Is that everything? I think I'm seeing the world through TB right now, unfortunately. But I think if you step back and you like now ask the question that Prof. Rez asked a while ago, which is why did this patient stop drinking? I think the reason that that's an important question is I think it helps us understand that this syndrome may possibly be evolving for 2 months. And I think that whenever you see a nodular opacities in this in a patient, you can make progress by understanding where those nodules are. Are they airway, lymphatic, or vascular? Of course, but I think you can merge them with the time course, and the time course here seems to be subacute. But I think if you practice just approaching this case from the anchoring your thinking around the brain lesions and then using everything else as clues, I think you come to the exact same conclusion. But that the process of that is to say, whenever I have multifocal brain lesions, I need to look down. I need to look at the rest of the body, and the rest of the body can tell me what's going on. And the assumption you're making is whatever's happening in the rest of the body is a clue to what's happening in the brain. So it all goes back down to the lungs. So what could you have found in the lungs? If you had found one dominant mass in the lungs, you would have concluded that these multiple ring-enhancing lesions are possibly metastatic lung cancer. If you had looked down and you would find hilar lymphadenopathy with perilymphatic nodules, you would all of a sudden start to wonder if this person has sarcoid. But you look down and you see nodules that are centered around the airways. And so that really should prioritize the fact that this is an infection going this way. And so I think that if you look at Prof. Rez's list, where Ibrahim was going with smaller and larger font, look at the sheer number of the organisms that are at play. But in real life, this is TB until proven otherwise for 2 reasons. The first is it's by far and away the most common cause of a lung brain syndrome worldwide, especially in Morocco. And then when you factor morbidity to the patient and morbidity to the exposure of the staff, this is why this is TB until proven otherwise. And in some cases, it will be proven otherwise because it's not TB 100%. And because it's VMR today, maybe that day. But I think in real life, this is TB until proven otherwise. But some additional nuances, if you take that whole list of lung, brain, and then you say, actually, let me apply a filter. And that filter be not just brain in terms of meninges or brains in terms of hydrocephalus. Let me just apply this as in terms of brain abscesses. And when you say apply the filter of brain abscesses, TB and nocardia are the most common. Histo can do it, blasto can do it, but the dimorphics and crypto tend to cause much more meningeal disease than they cause brain mass diseases. And these are all just propensities. They're not foolproof. So you should lead, I think, with TB and nocardia. And then the reason you would choose TB, even absent of base rate, is in most patients with nocardia, they usually have one or at most two brain abscesses. To have multiple brain abscesses would be more suggestive of TB. So I think, as Prof. Rez said, it's hard to skip over TB, and I think you'd be holding your breath until you know. It'd be and just to really play the game, if the AFB sputum is positive, the MTTBR complex, MTV PCR complex would help you confirm that. If it is negative, what would happen? If it's negative, your concern for TB would be so high that you would definitely begin to look elsewhere in terms of other causes, but you would recognize that the diagnostic tools to diagnose TB are highly imperfect. And so you would now have two pathways rather than just one. Any other thoughts, Prof. Rez, before
Yeah, Rabih, I had a question for you and the audience. Does the immune status help you at all here in terms of like prioritizing amongst those organisms you mentioned?
I'll just share my thoughts. I'd be really curious what everybody else thinks and what you think, Prof. Rez. I think that I learned that about a third of patients with nocardia are completely immunocompetent. The same number for Cryptococcus. So I think those two are fair game. I think we've been humbled by blastomycosis disseminating in an immunocompetent person. I think histo can do it. We had a case that Amal presented in an immunocompetent host who had histo. So yeah, I think that some infections like TB are much more likely to disseminate without immunosuppression. But yeah, I don't know. What's your take on that? What's your instinct?
Oh man, I was just curious because I use you as my GPT 4.5, so that's why I went ask GPT, you in the audience. But I do wonder, is it like specific organisms? If you are in, is it like not neoformans, but Gaddii, or can you gain any more clarity on that? Maybe this is more just out of curiosity. Is it like a specific nocardia species or that the immune competent is at more risk of?
I don't know about nocardia, but I think, yeah, for Cryptococcus gaddii is
Gaddii.
overrepresented.
All right.
Yeah.
All right, thank you.
Yeah, for sure. Yeah.
All right, back to you, Masa.
Hey, you guys are definitely leaning towards the diagnosis. I'm so impressed. So for CSF analysis, the protein was 2,443 milligrams per liter, glucose 3.5 millimoles per liter, and leukocytes were 64 with lymphocyte predominance. And acid-fast bacilli culture was positive. And so, shall I reveal the diagnosis? It was CNS tuberculoma, and the patient was started on anti-TB 4-drug regimen. Yeah.
I just want to say, Masa, this was first of all, let me just applaud on how you presented this case. I love your pauses, the information you gave us, and it led to a very rich discussion. And the tuberculoma in the brain, Rabih and I discussed the case on RLR, and I think I studied it for 20 hours. But if you ask me, like, what does it boil down to? I'd be like, I don't know. I have to go back and look at that infographic. So let me pass the mic to Rabih as I look at my infographic.
Oh yeah, I just really, I think, in some ways, you could have broken your goal of sharing the image earlier, but I'm really glad you didn't. And I think it goes to show you how much bread and butter thinking you have, basic teaching on seizure management, a basic teaching on alcohol use and how it can be impactful here. and analysis of the labs and, all the stuff that basically we got to do until, like, look at what Ibrahim has in store for us. It's all like bread and butter stuff. And yeah, I think at the end of the day, the biggest thing that turns out to be really helpful for me that I'd emphasize is a sense of the time course. Because if this happened acutely in a neutropenic patient, the same thing, acute and neutropenic, this would be an invasive mold like Aspergillus. And so a subacute, and I guess Prof. Reza's point of him being immunocompetent is so important here. Subacute immunocompetent changes the calculus dramatically. So thank you so much for such a rich case. And I also appreciate you leaving us clues along the way that this was going on by telling us he had visited a week prior, by sharing that he stopped drinking 2 months ago, and then I think most unambiguously telling us that he's had enough time to drop his temperature to 34. I forgot to reflect about that, and I'm going to read more about what that represents in this case, because I wonder if it is actually a central hypothermia, given what devastating neurological things you found, but I don't know that. Yeah, please.
Thank you so much. Thank you for letting me present. I know I've been on VMR for a while, but it took some time to build up the confidence to present a case. But I'm really glad I chose this one. It was really nice to visit it and learn more about it, like things that I didn't know before. To be honest, one big thing, which is like, I mean, for my level was very important, is that if someone comes with alcohol use disorder and seizures or like stopped suddenly, you have to ask why he stopped, like if something if he's feeling ill, if that's like why if that factors into why he stopped, and not actually like his motivation. I think that would be like, that's gonna be really important for the future when I'm dealing with patients, especially in like clinic. And yeah, I mean, I learned a lot of things. As you can see, Ibrahim wrote a lot of great things. Honestly, it was amazing as always. You guys have great teaching points, and yeah, thank you so much for having me. It was great.
You should read the chat, Masa. They're celebrating you. Great job. And Robbie, if you have nothing left to say, maybe we give the mic to Ibrahim and have him teach us.
Not going to pull up your infographic? I was waiting for it.
Oh, no, it's not worth it. It's primarily in the video.
Oh, I see. Okay. All right, Ibrahim, take it away.
Yeah, thank you, Robbie. Thank you, Reza, and thank you, Masa, for this amazing case. I struggled a little bit with the TPs, but I'll try to summarize as much as I can. So this patient, because they came in with a neurodeficient status, typically if a patient comes in and they're neurologically impaired, you want to stabilize them. And this is by way of controlling their seizures, controlling their blood pressure, and looking out for any cerebral edema that the patient may have. And then if the patient comes in and they have headache and vomiting coexisting with each other, you really want to think about elevated ICP. And you want to get a CT as soon as possible, especially as soon as we heard that this patient also had the right gaze deviation, which made us more concerned about the cortical process being in fashion here. And then we heard that this patient had used alcohol. And so in alcohol use withdrawal, you want to ask yourself the question, if stopping the alcohol use was intentional or unintentional. If it was unintentional, you want to think primarily of cirrhosis. And you also want to keep the risk of seizures in your mind. If a patient comes in and they're seizing and they also have a history of consuming alcohol, you want to get urine tox as well as blood alcohol. We talked a little bit about the gaze deviation that this patient had. And so in gaze deviation, you can have it primarily due to etiologies that either happen in the frontal eye fields, where you're going to have contralateral gaze deviation, or you can have it due to an etiology happening in the parapontine reticular formation, where you're going to have ipsilateral gaze deviation. If a patient comes in once again with seizures, you want to make sure to rule out the etiologies while you can. And those could include structural lesions, metabolic, and toxins. And you also want to ask about history of seizures happening before. We then delved into the hypothermia. And one important pearl that Rabih has shared with us is that hypothermia typically happens over time. And it can happen either because you have loss of energy, or you have decreased production of energy in your body. And the loss is typically either due to environment, vasodilation, where it can happen due to sepsis, alcohol consumption, or hypothalamic etiologies, where you typically see the cyclic hypothermia. We then later learned that this patient also had hyperbilirubinemia. And in approaching hyperbilirubinemia, you want to ask yourself the question if this is hematological in origin or hepatic. If it's hematological, this would typically be indirect, versus if it's hepatic, this would typically be direct. And if there's leukocytosis with the hyperbilirubinemia, you want again to think about alcohol. We then learned about the patchy opacities happening in the upper lobe. And if a patient comes in with a similar picture and they're young, and you're really thinking about an infection, think about an infection that can reach the brain, the lung, as well as the liver. And those would typically be atypical infections. So mycobacteria, nocardia, actinomycosis, but then also don't forget the dimorphic fungi. And this is typically dependent on the area in which the patient lives and which dimorphic fungi is endemic to that area. Those would include things like cocci, histoplasma, as well as blastomycosis. And then you can also think about an immune process such as GPA, rheumatoid, sarcoidosis, or malignancy. The practical steps here is that you want to start broad spectrum antibiotics. You want to send for sputum culture. You want to send for an MRI, an LP, an LDH because of the risk of a lymphoma, as well as an AFP smear. And finally, we heard about the nodular opacities. And typically you want to differentiate your nodular opacities based on their location. If they're happening in the airway, the lymphatic, or the vascular, if they're within the lungs. If they're within the brain, you can think about the opacities in terms of abscesses, especially if there are multiple and the patient's picture is mostly leading towards an infectious etiology. And here you can think about TB versus nocardia. And always remember that 1/3 of patients with nocardia are actually immunocompetent. And so consider those until proven otherwise. And also remember that mostly fungal are parenchymal or meningeal, I should probably say. And so you want to keep TB and nocardia at the top of your head in approaching such a patient. And with that, I think we've reached the end of our TPs for today.
Absolutely amazing, my friend. That was really cool. I think what really stands out about your teaching is the idea that you're going to punctuate the entire summary of the journey. But I think that the emphasis on the end of the brain-lung schema was well worth it. So thank you for spending extra time in that space. All right, y'all. Prof. Rez, a pleasure. Enjoy the rest of your day.
Take care. Bye, everyone.